the Raffles Cancer Hospital in Singapore and also visiting consultant at the Singapore General Hospital. And over the past 10 years, she's developed extensive experience in stem cell transplant for a range of autoimmune diseases, particularly multiple sclerosis, and has developed an international reputation, co-authoring with Richard Burt, one of the pioneers of stem cell transplant for MS, in a very, I would say, major article in Lancet, which was published just several years ago. In 2006, she spent some time with Richard Burt in Chicago, and then came back to Singapore, where she's now the head of the stem cell transplant program at the Raffles General Hospital. Before I ask Yvonne to come up and talk about the program, I thought I'd just show the centres in the world that offer stem cell transplant for multiple sclerosis. That appears to be active at the moment is St Vincent's Hospital in Sydney, taking, I understand, only patients from New South Wales because of funding issues. But you can see the other centres in Cape Town, in Hyderabad in India, Tel Aviv in Israel, Moscow in Russia, Heidelberg in Germany, and of course Professor Siccardi in Italy. In America, we have Richard Burt in Chicago, who's very active. How many transplant procedures would he do in every year?
I think it probably hit about 100 right now, maybe close to 80 per year. And he's the only transplant division right now. So.
Right.
That's difficult for one guy. Yeah.
There is another network in America where Richard Nash, I think, is offering transplant, and they're based in Seattle and several other centres. But Richard Burt is numerically probably performing more HSCT procedures for MS than anywhere else in the world. Just go to the final slide. Yep, we'll just skip through that. And here in Australia, you see we have experience in Australia with 3 centres, St Vincent's in Sydney, Perth and Canberra. The Perth and Canberra transplant programs are no longer active for reasons I'm not sure about, but may be related to funding. But in Sydney, you can see that Dr. John Moore, who heads the unit there, has done around about 20 HSCT procedures for multiple sclerosis, and in 7 out of the 20 there's been a recovery of disability to an EDSS of less than 1. A lot of that slide relates the good functions there are due to performing the HSCT procedure early in the disease course, and the less impressive results from Perth were obtained with people who had secondary progressive MS and a long disease course before they were enrolled for a transplant procedure. Thanks, that's all for that. So, I'd like to welcome Yvonne Loh, and over to you.
Thank you. Thanks so much for that kind introduction, and I'm really grateful for an opportunity to talk to all of you. Does that answer work? Or it's only a laser pointer, is it? Okay, so you are the slide advancer. Okay, so the first transplant was done almost 20 years ago, and despite that, it's far from being considered a standard of care. And everyone here in this room understands sometimes the fight that you have to get to be able to get this procedure done. So I thought that today I just thought I'd give a survey of how the field has developed over the last 2 decades, where we are now, and perhaps a glance into the future of where the field is taking us. But we don't know not everyone who has an underlying genetic predisposition to MS actually develops MS. There have been some studies to show that there are certain genes that you may inherit that may increase your likelihood of getting MS. And yet we know that not every patient who has those genes develops MS. Likewise, not every patient with MS you can actually track down a causative gene. And that's because there are a fair number of other factors that come into play. For instance, the underlying risk of perhaps a childhood infection, like having EBV when you're young. These are thought to be one of the possible causes or environmental factors that cause MS. Where you are born, and certainly in Asia and closer to the equator, the incidence of MS is much lower than in temperate climates. Dietary factors, vitamin D deficiency, for instance, but in a place like sunny Australia, where there shouldn't be a lack of vitamin D, why do we have such a high incidence of MS still? So there must be something else that comes into play. And of course, smoking. But not everyone, some of us have never smoked a single cigarette in our life, and yet we get MS. So it's all these things that interplay together. And what's important is there needs to be a lapse of many years before whatever putative triggering factor you were exposed to as a kid or as an adolescent before you eventually develop MS. Every day we have autoimmune clones being formed in our body, but not all of us develops an autoimmune disease. And the reason is that our immune system tries to keep the balance towards self-tolerance. There must be something that happens that tilts that balance, and it's a multiple sequence of hits. And this is what we learn from cancers. You don't just get one mutation and develop the cancer. It's usually a series of mutations and a lack of ability to eradicate those bad mutations that results in the development of cancer. Autoimmunity is kind of the same way. It's probably a combination of factors, an underlying predisposition, plus several triggering factors from the environment acting together that results in the development of MS. So this is a busy slide, but it shows the advancement in the understanding of how MS pathogenesis works. You have a misbehaving T-cell immunity that stimulates, it crosses into the blood-brain barrier, and it releases cytokines that increase this inflammatory milieu within the CSF. At the same time, you have B cells, which express CD20, and these they talk to the T cells. So the T cells stimulate the B cells, which develop into plasma cells that produce autoantibodies, and these also damage the cells that are responsible for forming the myelin sheath over the axon. But because of this, we now have druggable targets. So for instance, we have Tisabri, which acts on the alpha-4 integrin receptor, prevents the traffic of these T cells into the central nervous system. We have rituximab, which doesn't act on the plasma cells, but it acts on the precursor of the plasma cell, which is the B cell. We have drugs like alemtuzumab, which has just recently been approved. So this is an anti-CD52 antibody. As a hematologist, I know it as Campath, but now the drug companies decided to call it something else, Lemtrada, to try and divorce it from all its past history of treating CLL and lymphoma, okay? And then we have studies for drugs like IL-2 inhibitor like eclizumab, trying to prevent the T cells from getting into the central nervous system. So all these drugs potentially have a role to play in controlling the MS. Then we have this interesting entity, fingolimod. It's unique. It acts not just on preventing keeping the lymphocytes within the lymph node. It also acts within the central nervous system because the S1P receptor is expressed on a number of cells within the central nervous system, thereby quietening this inflammatory milieu within the CNS. Now the limit of all these drugs, however, is that most of the time the patients need to be on the drugs lifelong. It's okay. At the same time, most of these drugs do not tackle the underlying problem of self-tolerance. What they're trying to do is act on various pathways that mediate the MS pathogenesis without tackling the underlying problem of a lack of self-tolerance. In other words, you still have all these autoreactive T and B cells trying to attack the central nervous system. The long-term follow-up studies actually suggest that a drug like Tisabri may even have a sustained remission for more than 10 years. Back up. Yeah. However, there's concerns of things like PML, And patients do actually develop neutralizing antibodies against natalizumab. So over time, there may be a loss of response. At the same time, of course, we know that there are patients who, despite having received a number of these DMDs, continue to have relapses and continue to have symptoms of MS. So therein lies the underlying rationale for a transplant. I need to emphasize that a transplant does not repair the central nervous system. We are not trying to convert hematopoietic stem cells into new nerve cells. Now, you read the literature, there's all this hype, about things about how you can inject stem cells and it's like a fountain of youth. Suddenly, they're all well again. No, that's not how it works. The underlying rationale is the delivery of drugs at a high enough dose to be able to deplete the self-reactive T and B cells. But the side effect of the procedure, because you're delivering high doses of these immunosuppressive medicines, is that the white blood cells will drop, the platelets will drop, and therein lies the underlying risk of the transplant. But because we've already collected the hematopoietic stem cells and stored them, when the patient receives the drug to suppress the immunity, these stem cells have been spared, have been collected in advance, and they are spared the effects of the chemotherapy. When we infuse the stem cells back into the patient, it then hastens the recovery from neutropenia, thereby lessening the potential side effects. And because we talked about how there is a lapse in time between the exposure to whatever environmental elements set off the MS process and the eventual development of MS, we postulate that at the time when the transplant is done, whatever putative environmental trigger is done with, the childhood infection is in the past. So now when we try to reset the immune system, you can tilt the patient back into tolerance. So that time lapse is something that is important, and we're aiming to reset the immune system back to what it should be doing, which is to recognize self. Your brain and your spinal cord is not your body's enemy. So that's kind of how it works. So as the video had shown earlier, the transplant is a two-phase procedure. In the first, we call it mobilization and harvest. So basically, you start with a patient and we give them a drug, most commonly cyclophosphamide, in combination with progressive. And this has two purposes. The drug, cyclophosphamide, is active in MS. In fact, there's some studies that suggest that pulse cyclophosphamide will be able to control relapsing-remitting MS when used in that manner. So we hope thereby to quieten the disease down slightly, especially with patients who have fairly active MS entering into the transplant. The second thing that it does is because it renders the patient slightly cytopenic, it stimulates more cells to go into the cell cycle. And when we give G-CSF, these cells get pushed out from the bone marrow, they increase in numbers within the peripheral blood, and then they can be harvested through the machine. Now, all of us have a very small fraction of stem cells that circulate in our blood every day. The numbers are too small to collect at steady state. But a combination of cyclophosphamide and GCS will boost that by at least tenfold, making it much easier to collect with the machine. And so after about 2 days of collection, we'll be able to have this peripheral blood stem cells. Now in our center, we would first perform CD34 selection, and before they are cryopreserved. This is not done in every center, and I'll talk a little bit more about CD34 selection. Now this process takes about, from the first day of chemotherapy to the time we finish the harvest, approximately 2 weeks. After that, there needs to be a 2-week rest period because we want the patient to recover from the harvesting procedure. And we need a gap between the dose of cyclophosphamide that's given at the beginning and the dose of cyclophosphamide that will be released that will be given to the patient at the start of the transplant. So the second phase is the actual transplant phase. And so after a gap of at least 2 weeks, because the cells are frozen, we can theoretically extend the rest period between phase 1 and phase 2 for as long as the patient needs. We would then admit the patient to the hospital, and then we'll give them a combination of 2 drugs. With this, the blood counts will fall, and this is a non-myeloablative regimen, which we'll talk a little bit more also about later. We'll infuse the stem cells back, and after a period of about 9 to 15 days, the patients will recover their blood counts and will return to the pink of health and then be discharged. So that it all sums up the transplant process. Okay, so what is this CD34 selection? Now, this is something which we do, in which we take the stem cells that have already been harvested, and we add in CD34 positive, beads that will bind to the surface of the stem cell. I think that will really work. Okay. And then by subjecting it to a magnetic field, these CD34 expressing stem cells will be attracted to stay within the column, while the rest of the cells are allowed to pass through. So in the process, we deplete the T cells, which we think are most important for mediating the MS, as well as the B cells, because they don't express CD34, and what is collected is a relatively pure product containing primarily CD34 expressing cells. Okay, so how did transplants first begin? Usually, as with every other condition, with mice. So this is all the way back in 1992, where transplants were done in mice. And these mice were subjected to a combination of radiation, and they had a syngeneic bone marrow transplant. That means they're being given marrow from another little mate that is identical, okay? Like a twin. So that's kind of like how autologous transplant in a mouse setting will be done, because you can't actually harvest marrow directly from the mice and then expect them to survive the procedure only to go through a transplant. But in essence, this is an EAE model which tries to recapitulate as far as possible MS in a human. And the higher the clinical score, just like ADSS, the more paralyzed the mice are. And in essence, what happens is that the mice that were given radiation and the syngeneic BMT at different doses had a much lower clinical score compared to those that were not treated. What was interesting is that when they re-challenged these mice that had been treated, once again with the adjuvant that causes the EAE manifestation, none of the mice that had been transplanted actually developed paralysis again. This is compared to the mice that were never treated with a transplant. And this is something which I think is interesting because it may suggest that the procedure has actually restored tolerance in these mice to whatever adjuvant that they were given. At the same time, there were also some data of patients who had underlying cancer, like CML, who underwent a transplant for another indication, and you can see that the MS lesions after the transplant got better. So this anecdotal evidence plus animal model evidence led to the first suggestion that MS may actually so it was actually Richard Bird in 1995 who wrote an editorial suggesting perhaps doing an autologous transplant for MS may be able to be a means for treating the condition. And it was not until 1997 that the first transplant in the world was done, at the time by the Greek group under Fassas. And then 2 years later, Richard did the first case in America for SLE and then for MS. Okay, so what are some of the early clinical results, and how has this approach, the understanding, changed the approach and the understanding in the field? This is Fassas' initial data. He did almost half of his patients had secondary progressive MS, the other half had primary progressive MS, fairly advanced disease, and they all had failed therapies that were available at the time, like interferon and steroids. They were mobilized with 4 grams of cyclophosphamide. They had a multi-agent chemotherapy regimen. So BEAM consists of 4 drugs, VCNU, etoposide, Ara-C, and melphalan. And this is a very intensive regimen that we usually utilize in treating patients with lymphoma as well as with both Hodgkin's as well as non-Hodgkin's lymphoma. He combined it with ATG at varying doses, and followed up for about 6 months. He had a number of patients that stabilized, but he had almost all the patients have some kind of infection, and about 1/3 of them had new transient neurological deficits related to an engraftment syndrome. However, he thought the results were very promising. He had no deaths, and about maybe 46% of them improved by at least 1 point. Okay, so this was very early data. When you combine these results together with the whole of the European group for blood and marrow transplantation, you have a mixed bag. We actually have a mixed bag of regimens comprising the Greek, BEAM and ATG, but we also have very intensive regimens like cyclophosphamide and TBI, with a combination of busulfan and cyclophosphamide and ATG. And this is also a very myeloablative regimen that we use for treating leukemias. And not surprisingly, they had a TRM of about 6%. So 5 of the patients actually died. Half of these patients were actually from the Greek group. Okay, but this was kind of the data that was over in Europe. Now this is how when we followed the patients up for a duration of time, patients with a secondary progressive and relapsing remitting MS had about 80% progression-free survival, while those with primary progressive MS did worse at about 60%. Now, in the meantime, things were happening across the Atlantic in America. So as Tom was mentioning, there is a group from Seattle, and this is actually a Seattle consortium of several centers who did transplantation using cyclophosphamide and total body irradiation. So this is a very myeloablative regimen in combination with ATG, but they mobilized the patients for only GCSF, which unfortunately resulted in a flare, and fairly advanced patients, most of them with secondary progressive MS and a fairly high EDSS. At a follow-up of 2 years, this was what they found. The majority of the patients stayed the same. So those with secondary progressive MS, stable or no change, about 12. There were 4 that did worse. Only 1 patient in the group had relapsing remitting MS, and he actually appeared to get better, while those with primary progressive MS remained the same. So overall, this actually showed that there was stability with no improvement in the EDSS in the main. Now, because of the nature of the regimen, many of them ended up with engraftment syndrome. Amongst the seropositive patients, about half of them reactivated the CMV, but one of the patients actually had CMV disease with pneumonitis and gastroenteritis, which is a severe complication of a CMV infection. Now, interestingly, in the very same issue of blood, Richard Bird actually reported on experience using a high-dose regimen with total body irradiation, very similar to what was used in Seattle, but with a higher dose of radiation, up to 12 gray. His conclusions were quite different to what was being reported in Seattle. Now, he had no deaths as well. Again, 5 patients with engraftment syndrome. And in his earlier cohort of patients, he followed them up. He recruited patients with a much higher EDSS, and he followed them up for about 2.5 years. Midway through the study, he took patients that were earlier on in the course of the disease, and these had a shorter duration of follow-up. Now, even though he had no severe toxicity, what he found was that most of the patients had EDSS actually worsened, about 8. A number of them stayed the same, and there were only 3 patients that actually had an improvement in the EDSS by 1 or more. And these were the patients that were recruited with relapsing remitting MS and who had a much earlier course of the disease. The EDSS, less than 6. So when he did a post-hoc analysis, those patients who were followed up for a shorter period of time but had a lower EDSS had no progression at the time of the writing of this paper, and whereas the patients with an EDSS more than 6 actually did not seem to benefit from the transplant. Now, he was very honest in reporting his results, and as a result, they changed their regimen from there on to not use TBI anymore. So total body radiation is a regimen that we use classically in the treatment of acute lymphoblastic leukemia. And when transplanters first started doing transplants for MS, it was natural for them to borrow from the existing regimens that were there in use. So he used TBI, but he thinks that what he mentioned in his paper was that perhaps the radiation may in fact interfere with recovery of the central nervous system after the transplant and may actually cause more damage to the CNS. And that's why they moved away from doing TBI, and he started to have a combination of cyclophosphamide together with either CAMPATH or ATG. Interestingly, though, coming out from this group, from this trial, they actually sent some of their blood for further analysis at the NIH. So same protocol with cyclophosphamide and TBI, and you can see Richard, one of the authors of this paper. They actually did an analysis of what happens to the patient after the transplant. So I'm not going to go through in the detail what this means, but in essence, what it shows is that the younger or more naive T-cell phenotype actually starts to increase from the 6th month onwards, suggesting that these are recent emigrants from the thymus. The transplant seeks to re-educate the immune system to tilt it towards a more naive phenotype as opposed to the effector memory cells, which are the established T cells that may already be causing the damage to the CNS. And so this data suggests that we have now generated a new, more naive immune repertoire, and perhaps we've restored tolerance. So this is something which is a proof of principle of how the transplant works. Now, this paradigm shift of a move from a myeloablative to a non-myeloablative conditioning is something that is important. Now, when transplants were first conceived around the world, they were always myeloablative. The underlying rationale is you have a leukemia, it's a nasty disease, and you want to give the intense enough regimen to kill off whatever leukemia cells are left in the patient and then replace it with a healthy marrow. So that's how transplants began. So the term myeloablative just means you're ablating the marrow. Okay? So examples of myeloablative regimens will include things like cyclophosphamide and total body irradiation, and busulfan cyclophosphamide. And BEAM is somewhat closer to a myeloablative regimen on this end of the spectrum. And what it means is that if you give these drugs at these doses, and you don't have a stem cell graft, they are going to die from marrow aplasia. The hematopoietic stem cells do not have the capacity to recover on their own. In contrast, when you're using a light regimen like Cytoxan and ATG, or fludarabine and Cytoxan, you're giving a light regimen. Even if you didn't have a stem cell graft, the patient would eventually maybe taking 1 or 2 weeks extra to recover their blood counts, but they will eventually recover their blood counts. So that's the concept of a non-myeloablative regimen. Now the drawback, of course, is that when you're using a myeloablative regimen, you have more toxicity. But on this end of the spectrum, you have a higher risk of relapse. So they're called balancing the two. And how did these terms first come about? It was actually not until the late 90s that people began to understand that the underlying concept of doing a transplant from another donor was that you didn't always need to give a very high dose of chemotherapy or radiation to be able to get rid of whatever bad cells are in the patient, because you're giving a new donor-derived immunity to the patient to fight away the leukemia or whatever malignancy that you're treating. And so it was somewhere in the late 90s that this term non-myeloablative began to come about. But they were always applying to allogenic transplants. Based on the way autologous transplants were conceived for malignancies, they always had to be myeloablative, because the underlying rationale for an autologous transplant for malignancy is dose intensification. You have a patient with a disease that is sensitive to chemotherapy. Let's give more chemotherapy. And because this may cause their blood counts to fall, let's first collect the stem cells and put it back. So autologous transplants, by definition, in malignancies are always myeloablative. So when Richard first put this term together of a non-myeloablative autologous transplant, that's actually an evolution in the understanding of how autologous transplants work. But that's because when it comes to an autoimmune disease, you don't need myeloablation. It's an unwanted side effect of the procedure. You also increase the toxicity when you do myeloablation for an autoimmune disease. Now, when you're dealing with a disease like AML, acute myeloid leukemia, where patients would succumb to the disease within 6 months without treatment, then there is some acceptable toxicity. And as a transplant doctor who takes care of malignancies, I would be willing to accept a potential mortality of 5% in my leukemia patients, because you're dealing with a disease that's invariably fatal without treatment. So it becomes an acceptable risk. But when you have a condition like rheumatoid arthritis, a condition like MS, where patients don't die within 6 months of the disease, it is unacceptable to have a toxicity even of 1%. So therefore, it makes sense that you want to shift away from toxicity, from the high toxicity regimens and high intensity regimens towards one which is lighter. But you still want to have the effect that you want, which is lymphoablation and not myeloablation. So that's basically where the field went. And so in 2006, we put out a position paper saying that you should not be doing transplants for myeloablative diseases when it comes to autoimmune disease. You should not be using a myeloablative regimen, but one that is lymphoablative. So when he put out this paper, there was some unhappiness in the field, but this is basically where I believe the field should be, and that's the reason why I do not use a myeloablative regimen for any of the transplants for autoimmune diseases. It is an unacceptable toxicity for the patient. So our whole MS study is an NIH multi-center study, and it's being driven by Richard Nash with the Seattle Consortium. Initially, he had planned to do it with TBI way back before the trial was first approved, but eventually he decided on a BEAM ATG regimen similar to what's being used in Europe. The ESTIM study is another study now that was ongoing in Europe, multi-center, driven by the European Blood and Marrow Transplantation Group. They randomized patients between two arms, BEAM and ATG is one arm, and the other arm was mitocentral. Now, unfortunately, because of the comparator arm that was extremely unpopular and has also fallen out of favor, even though they designed the trial in 2003, the study was terminated in 2009, having recruited only 21 patients of a 100 over patients. and they had 12 patients on mitochondrial and 9 on HSCT. The whole MS study is supposed to be ongoing, but if you look at clinicaltrials.gov, they are not actively recruiting patients anymore. But just this year, Nash reported on his 3-year interim results. He stuck to the same regimen of using only GCSF for mobilization. He did the CD34 selected PBSC. He gave a combination of BEAM and ATG. And now he is taking patients with relapsing remitting MS primarily, and a fairly low EDSS. They had no deaths, but about half the cohort had infections. This is his very early results. A fairly good progression-free survival, about 84%. Now this is the unfortunate European study that was very long in the conception. But as I said, because they designed it to randomize with mitoxantrone, there was just a difficulty in recruiting patients. And so it took many years, and they only recruited 21 patients. The mobilization regimen is slightly more intensive, with 4 grams instead of 2 grams of cytoxin. And they use BEAM and ATG at a slightly higher dose. And they give the ATG after the PBSCs on day 1 and day 2. They did not report very much on the clinical activity because the way the study was designed, or the numbers that they recruited, the numbers were not enough to derive any kind of conclusion in terms of the clinical outcomes. But based on MRI findings, there was a significant improvement in the transplant arm in terms of the number of new MRI lesions developing after the transplant. So this brings us then to lymphodepleting regimen as used by Richard in Northwestern. Very early patients, EDSS of 3.1. They mobilized with 2 grams of cyclophosphamide. They get cytoxin at 200 milligrams per kilogram. And the earlier cohort, they had alemtuzumab. Later on, they moved to using ATG because of a higher incidence of secondary autoimmune diseases with alemtuzumab. And a follow-up of about 3 years. This is what we reported. The EDSS significantly improves in most of the patients whilst on the study. Fairly short follow-up, as I said, a median of about 3 years. And so did the 25-foot walk time. So because we found that there was an increased risk of getting a secondary autoimmune disease, we actually decided to switch the regimen from using cyclophosphamide and ATG, and cyclophosphamide and alemtuzumab to using cyclophosphamide and ATG. And so now, just this year, he actually published in JAMA an update of now 151 patients. You note, because the study criteria takes only relapsing remitting patients, only 55 of these patients were actually done on study. 28 of the secondary progressive MS patients were done off study, as well as a good number of relapsing remitting patients who did not meet criteria either because they were too old, because they take a cutoff of 55 years of age, or because the EDSS was slightly above the range that he would accept, or because of the lack of insurance funding for a trial. So they were all done off study. And this is the results with the EDSS that improved over a period of up to 5 years follow-up with a sustained plateau that you can see on the EDSS. Now, this is from the supplemental data that you can see on this online publication. We did a post-hoc analysis looking at the patients who had relapsing remitting MS versus those who had secondary progressive MS. So you can see that there's stability, but unfortunately a lack of improvement following transplants for patients with secondary progressive MS. But most of the patients with relapsing remitting MS improved and continued to remain well up to 5 years of follow-up. When you looked at the subset analysis of patients who were transplanted with more than 10 years of history of MS versus those with less than 10 years of history of MS, you can see that it's the patients with a shorter duration of disease that did better compared to those who had MS for more than 10 years. So we're going to shift now and talk a little bit about our Singapore experience. Now, the regimen differs from what has been published partly because of historical reasons. The first transplant patient that we did for MS was all the way back in 2002, when there was hardly any publication in the literature to guide us on what is the best therapy. What we knew is we wanted lymphodepletion, and so the CD34 selected PBSC was there. And we used a combination of fludarabine because we know that this is lymphotoxic, but not so much myelotoxic. And we use a combination, the same dose of cyclophosphamide at 50 milligrams per kilogram per day for a total of 200 milligrams per kg over 4 days. With this, the patients will have neutrophil engraftment at about day 9, so the blood counts will start to fall somewhere here, and they start to come up at about the 9th day, or the platelets may take a few days later, maybe at from about 16 days onwards, the platelets will recover. And most often, patients will stay in hospital for a period of about 3 weeks. So it's a mixed bag, and this is just a kind of like retrospective analysis of our first 13 patients. The first 4 had secondary progressive MS. 7 of them had relapsing remitting MS, and before we knew better, we actually took patients with NMO. So the thing is, people used to think that NMO was like a Asian variant of optical spinal MS. So in NMO, they have mainly optic neuritis together with spinal cord disease, but the disease is actually quite different. And now the disease entities are known to be quite separate. But at the time when we did these patients, we weren't able, or we weren't so much aware of the differences between NMO and MS. So my cohort includes patients also with NMO. The median EDSS of this cohort is about 5. The range of as low as 1.5 to as high as 9. They all had the same regimen with fludarabine, cyclophosphamide, and Z34. I had one significant toxicity. There was a man who was paraplegic at a time when he came for a transplant. Unfortunately, during the transplant, he developed a perianal abscess. And because he had no sensation below the waist, he didn't know the abscess was there. And he was a man who didn't want the nurses to be with him when he showered. So unfortunately, by the time we discovered the abscess was there, it was large and very, very established. He had severe sepsis. His EDSS got worse following the transplant. Eventually, he succumbed to pneumonia 6 months after the transplant. We had 2 patients that we did in 2006, not knowing that we had NMO. Unfortunately, they did well for a period of time, but unfortunately, they fled maybe about 6 months after the transplant. The patients that improved primarily had an EDSS less than 5.5. 2 of my patients out of the 13 had CNV reactivation, despite the fact that there was 100% seropositivity pre-transplant. And 1 patient had bacterial sepsis, the one that I mentioned up there. So this is the serial EDSS of the patients. These are the 2 NMO patients. You can see they appeared to be stable for a while, and then they fled and it got worse.
So are you saying that NMO is not suitable for HSCT?
They need a different regimen. So we'll talk a little bit about that. So it needs to be treated differently because NMO has a lot of B-cell mediated disease. So I will use the same regimen that they're also studying now in Northwestern, which is a combination of Cytoxan, ATG, but with rituximab, and maybe with plasmapheresis before we start the conditioning. So they probably need a slightly more B-cell depleting type of procedure. Okay, so if we exclude these patients, most of the patients that got better were those who had relapsing remitting MS and were done early enough in the course of disease. Patients with secondary progressive MS more or less remained the same, and this was one of our early compassion transplants. So we did it because she's young. She's a young kid. The neurologist begged us, and there's really nothing else to do. And we felt sorry, so we did it. But in retrospect now, I would not have done it. She did okay during the actual transplant, but she got worse about a year after, and then she eventually succumbed in a nursing home. So there's just some patients that are too advanced and beyond the ability of the transplant to fix, which is why we explain we do not grow new nerves with the blood stem cells. It's just to hasten the recovery from neutropenia and restore tolerance. And it's over time with physiotherapy, with the lack of new flares, that the nerves have the capacity to recover and get better. This is just some data. So I had a grant from the government to do transplants, but it's a joke that we have amongst researchers that once you open a grant and you have funding for a research project, the patients stop coming. So even though I have funding for like 10 or 15 patients to also to pay for part of the transplant, unfortunately I was only able to recruit 3 under that actual study. So this is just to show that the proportion of cells that express CD39 positive, this is actually thought to be normal regulatory T cells that affect the ability of the immune system to be self-tolerant. And the numbers actually come down following the transplant. So this is very short follow-up. After that, we went on with grant funding. So now all patients are done off study. So this is just, let's move on. So what are the conclusions that we have? Basically, we've now done transplant for 20 years. So we know that we can be done safely. You should aim for a TRM of less than 3%. Based on our experience with doing autologous transplants for lymphoma that we now can do so safely, we have a TRM of about 1% for myeloma and lymphoma, despite a much more intensive regimen because of good supportive care. So these are the caveats. You need to have low toxicity. We know that we may actually restore tolerance, and the patients can come off in the majority of disease-modifying drugs once the transplant is done. The problem now comes with patient selection. If patients have more advanced disability, long duration of disease, or late secondary progressive MS, and in Richard's series, interestingly, he found that patients who had fever in the course of the transplant had worse outcomes. So we had to try to prevent infections during the transplant as far as possible, because those without fever have a much better chance of improving after the transplant.
What do you consider long duration?
Yeah, so that's the thing. In Richard's series, because he's got the biggest series and the longest follow-up, he found that those who have MS for more than 10 years tended to not do as well as those who have MS for a shorter duration. So this is the problem. Exactly how long do patients have MS? Because we know the diagnosis is not one that is absolute. You have to have two separate events, and sometimes the past events are missed. I saw a patient recently who had optic neuritis in one eye, and then like 3 years later had optic neuritis in the other eye, and at that point, still not diagnosed with MS. And then a few years down the road, she decides to go and see a neurologist, and then they did an MRI because she was getting weaker, and they found that she's got MS. So exactly when did the disease start? Was it 2002 when she had her first optic neuritis? Was it when they finally labeled her as MS? This is the problem when you have a condition where your definition is a little gray. It's based on a clinical syndrome. There's no one test that you can do that says, okay, this patient has MS. When it comes to a malignancy, it's easy. You either have the cancer or you don't. Once you do the test and you prove that you have a malignant cell, you're given that label. Now with MS, because you count it at a point of first symptom, it may not even be when the MS was first diagnosed. There's also a lack of objective measures of response, like the continuum between SPMS from relapsing remitting to secondary progressive. It's a continuum, right? It's not, your body is not an on-off switch. You can't say that at 4 years and 11 months this patient has this condition, and suddenly at 5 years and 1 month, suddenly the transplant won't work anymore. So the problem is that the patients gradually evolve into that phase, and we don't have a means of measuring what's going on in the CNS. Even your oligoclonal bands are a very insensitive marker. What it's telling you, in essence, is that you have a few clones of B cells that are producing antibodies in an abnormal fashion. That's all. It doesn't tell you what happened when the T cells first started going into the CNS to cause that. You don't have a marker from the blood that you can say that this is inflammatory phase of MS. So in the Northwestern series, they take patients with an inflammatory disease. But relapsing remitting is clearly an inflammatory disease. When you start to go into secondary progressive, there is still inflammation going on. However, when you define SPMS, it's a syndrome once again. So when a neurologist labels you as having secondary progressive MS, how do we know at that point whether or not you still have inflammation in the brain? We do an MRI of the brain and spinal cord. It gives you some idea, but there's no way for you to sample and say, okay, the T cells are now behaving this way, the B cells are now behaving this way, and there's still ongoing demyelination, or is it now a dying off of the nerve cell? So this is the problem. We don't really know the best time to do it. We know that you do it, the earlier you do it, the better. At the same time, we also cannot subject patients to late toxicities who are too early in the disease. For instance, there's some patients who have optic neuritis once, and for the rest of their life, they're totally fine. Or they may have one other symptom and they're labeled as MS, but they do well for the rest of their life. So if I were to do a transplant on them, it would be subjecting a patient to a treatment that is way more intense than they need. And you're also exposing them to long-term risks. For instance, there's risk of secondary malignancies maybe 10 years down the road. Secondly, there's a loss of fertility, because most patients who go through a transplant procedure will not have a return of their normal menstrual cycles after that, especially if the transplant is done in their late 30s or early 40s. So early is good, but how early? And too late, what exactly is too late? We actually don't really know. Okay, so we think that this issue of also novel agents versus transplant. Now, in this field, you have an argument between neurologists who believe in transplants and those that don't. Now that you have new agents coming up every few months, new agents that are approved for the treatment of MS, you have this situation where they want to try every new drug before they eventually send you to the rheumatologist. And as more drugs are added to the armamentarium, the inclusion criteria for trials may also begin to change. It used to be that you just had to fail interferon and steroids. Maybe now you need to also fail tizarafine and fingolimod before you can come on the study. So the number of DMDs that you have to fail before you come in also becomes a problem. So I thought we could take a lead from the myeloma study. So in myeloma, when we first started years ago, there was nothing that really worked. And so when there was autologous transplants for MS, and we could improve the survival by just a mere shifting the curve somewhere from here to here, this was like groundbreaking autologous transplant data with patients with multiple myeloma. But then somewhere in the 2000s, many new drugs for myeloma came on the market, and now the curve is shifted to somewhere like here. Now, it's easier for us because we are the same doctors that treat multiple myeloma and that also do the transplant. And so what we know is that it's not either or, but a combination that actually works better. And the idea is that if you can get the patients into a much better remission after the transplant, you're just making the transplant work better. So you're collecting stem cells that are cleaner. The patients come into the transplant in a much better state compared to before when we had to give them multi-agent chemotherapy before the transplant. And the effect of the transplant also becomes more sustained. So there's perhaps a possible role of even of using a novel agent for maintenance after the transplant. And if you have one that is orally administered with low toxicity and you're using it for a finite duration, why not? Maybe these are the patients that you had very active MS beforehand, and you may be able to reintroduce the agent for a short period of time after the transplant to improve their outcomes thereafter.
Are you talking about DMDs?
Yeah, why not? So it shouldn't be an either or thing. I think that novel agents can work in concert with the transplant. We just need to decide when is a good time for it to do. Because I think the transplant should be part and parcel of the treatment of patients with MS who are relapsing who are progressing despite one or two good agents with like a DMD, and despite that getting worse, before they go down to a secondary progressive MS state, and before the disease has been there for too long. So that's kind of how I think the field is and where it's at. So a little about us, I think you've seen a little bit about Raffles. This is the hospital. It's a multidisciplinary hospital encompassing most specialties. And Raffles Cancer, this is in future, a new building that's coming up just next to the existing Raffles Hospital to expand our services. And the Raffles Cancer Center is part of the Raffles Hospital, and this is our team of nurses together with multidisciplinary physiotherapists as well as pharmacists working together in concert for the good of the patient and some of the patients that were treated over the years. Thank you.